Bronchiolitis is defined as a lower respiratory tract infection which causes inflammation and congestion in the small airways. RSV is the most common virus that causes bronchiolitis. A whopping 2/3 of infants have an RSV infection in the first year of life. 2 to 3% of primary infections will require hospital admission, and 2 to 6% of these admissions need management on paediatric intensive care units. Its annual admission rate in the UK is rising, and NICE estimates an average of £516 for an inpatient stay, which is not dissimilar to costs seen in other European countries. So it's a prevalent and somewhat costly condition. So how do we treat it? Well, in 1941, Hubble and Osborne described its treatment in the BMJ, which included digitalis, emetics, mustard, venesection, and blood transfusion. Brandy, whiskey or port were recommended to be the best sedatives, and bronchoscopic aspiration was also recommended to prevent self-drownage. But still, even then, they understood the treatment was mainly supportive, including feeding children in warm, moist settings and ensuring an adequate oxygen supply. Thankfully, since the 1950s, our practice has changed, but still remains fairly supportive, with fluid and oxygen supplementation when needed being given. There is no evidence to suggest antibiotics, salbutamol, systemic steroids, or montelukast reduce the illness duration, and the role of 3% hypertonic saline and bronchodilators is still being debated. Palivizumab is a monoclonal antibody which can be given for RSV prophylaxis, however only available on the NHS for high-risk patients. The most important recent innovation in the treatment of bronchiolitis, however, is non-invasive oxygen support with high-flow nasal cannula, or HFNC for short. It has already been used in neonates for about a decade, but its use in paediatrics is more recent and is generally restricted to children with moderate bronchiolitis. In a recent literature review, it was concluded that HFNC may well decrease the need for invasive ventilation and to a lesser extent for CPAP. Many of the studies were equivocal when comparing CPAP to HFNC outcomes, but HFNC is 30% cheaper to use per day. The HFNC system has few parts: an air-oxygen blender, a gas humidifier, a flow generator, and the cannula. It works by administrating heated and humidified mixture of air and oxygen at a higher flow than the patient's inspiratory flow, which provides a great degree of distending pressure to the alveoli. The pressure is determined not only by the flow, but also by the ratio of the prong to nostril fit, and whether or not the mouth is closed. Therefore, there is great variation in the inter- and intra-individual pressures. By varying the flow rate and measuring pharyngeal pressure, it has been found that at below 7 litres per minute, the pressure varies with inspiration and expiration in a sort of sinusoidal shape. But beyond 7 litres per minute, the pressure remains positive, thereby generating real CPAP. In the absence of international guidelines, the accepted practice for HFNC in children is to use flow rates greater than 6 litres per minute, with 2 litres per kilo per minute being the most common practice. One study suggests this generates on average about 4 centimetres of water pressure. HFNC presents several advantages over conventional low-flow oxygen therapy. Firstly, it reduces air trapping. Bronchiolitis is a type of severe obstructive lung disease with a marked increase in inspiratory resistance and reduced alveolar compliance. This means air flows in and is difficult for it to flow out, so the air becomes trapped. The gradual increase in end expiratory volume generates a positive end expiratory pressure, or autopeep. Normally, to breathe in, contraction of respiratory muscles creates relative negative pressure intrathoracically compared to the extrathoracic pressure, and so air flows in down its pressure gradient. In obstructive lung disease, for the inspiratory flow to occur, the work of breathing is increased because at each inspiration, the patient needs to use their muscles to create relatively more negative intrathoracic pressure to offset the autopeep and to overcome the increased airway resistance. With the CPAP effect of HFNC, the positive pressure at the beginning of inspiration may compensate the inspiratory burden related to autopeep and facilitate inspiratory flow. In addition, the positive pressure during expiratory phase prevents alveolar collapse. Secondly, it's thought to result in better oxygen delivery and reduces CO2. The high flow of oxygen washes out the oropharyngeal dead space, which is the end expiratory oxygen-depleted gas. So in the next breath, the patient inhales pure oxygen. Dead space washout also reduces CO2 rebreathing. This is a significant effect in children as their extrathoracic dead space is proportionately 2 to 3 times greater than that of adults. Thirdly, the pressures generated by the device also prevents pharyngeal collapse, thus reducing obstructive apnea, which may be very pronounced in conditions such as bronchiolitis. Using technetium-labeled polystyrene tracer particles, it has been demonstrated that HFNC improves mucociliary clearance and airway defences. It also increases patient tolerability. The dry and cold oxygen of conventional nasal oxygen cannulae causes upper airway dryness, which leads to increased nasal mucosal resistance. With HFNC, the flow rates can be higher because the humidified and heated oxygen reduces the airway resistance, thus increasing inspiratory flow, reduces skin breakdown around the nose, and is better tolerated by the patient. In children, this benefit shouldn't be underestimated, both in terms of reducing the need for sedation, as is commonly needed with nasal CPAP, and also in terms of improving the quality of carer experience. Lastly, the increased work of breathing in this condition can quickly lead to decompensation in infants because their respiratory muscles are poorly equipped with oxidative fibres and so they fatigue quickly. However, HFNC reduces energy expenditure by reducing the work of breathing. Practically too, it has some advantages in that it takes relatively little time to set up and it can be initiated in the emergency department, expediting treatment. However, like any respiratory support system, this device has drawbacks. For example, it's noisy, it can result in gastric distension, the nasal cannulae can become blocked due to increased secretions, and there can be air leak if inappropriately sized prongs are used. HFNC also has its contraindications, which are thankfully rare. The main problems are because of the great intra- and inter-patient variation in the pressures generated in the airways, and there is a risk of alveolar damage, with a handful of cases of pneumothorax and pneumomediastinum being reported. The greatest risk in HFNC, however, as in any non-invasive ventilation strategy, is that it may delay mechanical ventilation and so may actually increase mortality. Thankfully, this has not yet been shown in paediatric population studies. For children, one prospective observational study showed that intubation rates after HFNC in bronchiolitis ranged from 8 to 19%. Predicting which patients with bronchiolitis are too severe for HFNC can be tricky. One large retrospective cohort study of 498 children with respiratory distress found that 3 main factors were associated with failure of HFNC therapy, which were respiratory rate greater than 90th centile for age in triage, initial venous PCO2 greater than 50 millimeters of mercury, and initial venous pH less than 7.3. In 2 other studies, the HFNC failure tended to occur between 7 to 14 hours after initiation, whereas studies looking at other NIV strategies, failure tends to occur within the first 2 hours. Because these weren't randomized controlled trials, it is not possible to make direct comparisons, but it suggests that HFNC should be initiated in areas that are sufficiently staffed to closely monitor the patient's clinical course so that the early signs of failure are recognized. Because HFNC has only been introduced in my local hospital for less than 2 years, we are yet to measure the benefit of a local population level. But in the literature, only case control studies were found, and they showed a PICU admission was 4 times less likely in children receiving HFNC, than children receiving standard treatment. Another small prospective observational study, including children with bronchiolitis, found that length of stay was reduced by 3 days in children receiving HFNC than children receiving low-flow oxygen. And finally, another retrospective bronchiolitis study found that median hospital stay was 4 days versus 3 days before versus after the introduction of HFNC in their general wards. HFNC is now being used in other settings, such as pneumonia treatment, asthma and withdrawal of invasive ventilation, and already in adults there is experimentation of its use in weaning tracheostomy patients and in being used even prior to extubation to help reduce the risk of reintubation due to laryngeal edema. The follow-on into the paediatric arena is yet to be seen. So in summary, HFNC is thought to improve outcomes by increasing patient oxygenation and reducing CO2 rebreathing. It has been shown to reduce PICU admissions and to be cheaper than CPAP, but the evidence for its use in the literature is low and it's not without its complications, so close observation is required. Thanks for watching.